Hello. First of all, welcome to the second day of the SGS Virtual Family Conference. I'm Karina and I'm from Denmark. So if there's a little bit with the accent, then that's why, and I might do some grammatic slip-ups, but I hope that you'll manage. First of all, I want to say that I'm from the Schinzel-Giedion Foundation, and today we have an amazing lineup. Thank you all for coming. And then Nuala, you can just give me the next slide, please. Thank you. First of all, there's a little bit of practical information. This meeting is being recorded for you to find it later on. If there's anything that you miss or want to know more about, again, then you can find it online and we'll give you the info later on. A big thank you to our speakers from yesterday, and that was Dr. Christy Ziegler and Chris Russell for their time, and also a big thank you for our speakers today, Dr. Jessica Duis and Anna Fangmeyer. We're very pleased that you want to spend your Saturday with us. That's really amazing. If you have questions for any of the presenters today, then just raise your hand. You can put them in the chat box and we'll keep an eye out if there's anything that you want to know more about. As I was saying, I'm a part of the Schinzel-Giedion Syndrome Foundation trustee group, and I'm not the only one doing a job there. We have Nuala, she's a big boss, I think. She's the chair of the foundation, and she's also the mother of Ophelia. And we have Emma, she's the trustee secretary and newsletter responsible, and she is the mother of Jude. Charlotte, she's in charge of fundraising, and she's also the mother of Avery. And then we have me, I'm the mother of Emma, and I work mostly with social media and the graphics. And then Dana has recently joined the trustee group, and she's working on the patient registry that you'll know more about tomorrow. I'm going to give a quick, oops, I'm sorry. The Schinzel-Giedion Syndrome Foundation, just to give you a little bit more info about who we are. We're a registered UK charity, and we were established in November 2019. Our board of trustees is a group of parent volunteers, and we're from all over the world, as you can tell from my accent, many of whom have children with SGS. And we're very fortunate to have a really good expert team of scientists and medical doctors on our advisory board. And our foundation has been created to represent children with SGS and their families living all over the world. Just to give you more info about our mission and our vision. Our mission is to create medical and scientific partnerships to facilitate awareness, research, and knowledge sharing, and to provide support for families of children with SGS syndrome. Our vision is for a future when all children with SGS will receive a rapid genetic diagnosis and have access to effective therapies to ensure they live longer, healthier, and happy lives. I'm going to give you a little bit of a recap for the first day, just a brief one, and then I'm going to tell you a bit more what's going to happen today and also introduce the first speaker. But first of all, we're just going to start with the first presentation that we had yesterday, which was Dr. Christy Ziegler, who talked about the ORCA study. And that's a measurement tool or a questionnaire that reflects communication ability of individuals with neurodevelopmental disorders that impact verbal speech. The intended use of the ORCA measure is to assess an individual's baseline communication and also the changes in communication ability over time in a research study, for example, in clinical drug trials. The questions are designed to extract the subtle ways of communication, and the researchers of the study is talking to families to understand how different the ways of communication are affected in different developmental disorders. And the key in this is actually that the questionnaire is designed to be used by parents and caregivers of a child. The reason it's important is that we want to know more about the way that our children are communicating, and we want to be able to share that knowledge with researchers so that we can maybe at one point have drugs invented for a treatment of SGS. A lot of the more conventional methods to assess communication are not meant for kids with SGS because it would look like they're not communicating at all. So the ORCA study is sort of a standardized tool to establish how the kids are communicating. And also these studies are very important because as it is now, it's the parents from all over the world that are the expert in this syndrome. So by being a part of more studies and getting this knowledge out, then we can get this knowledge out into the literature so that we as parents don't have to be the experts, but we can have that knowledge shared all over the world, and also for future parents that don't necessarily have a community like we have today in the Facebook group with a lot of knowledge sharing from parent to parent. And the way that SGS families can be involved, there is actually already some families involved, but you can contact us on our email. You can find that on our website, or you can write it down right now. It's contact@sgsfoundation.org. You can reach out, and there's already some families interested. And all it takes is actually just a 1-hour interview where you talk about how your child is communicating. That was it from Dr. Christy Ziegler. Then we also had Chris Russell telling us a bit more about CVI, or cortical visual impairment. And CVI is a child's way of understanding and seeing the world as they're a part of. So the CVI is a brain-based visual impairment that's caused by damage to the visual impairment pathways or visual processing areas of the brain. And what Chris was really clear about is that CVI is not a static diagnosis. There's room for improvement, no matter what your sort of baseline or your starting point is. So there's always room for improvement with the right training. And he told us a bit more about how we could train with the kids, for example, the use of color, the use of non-complex backgrounds, highlighted items with more light movement, and also that some kids might have a visual field preference for where their CVI is working with, where they can see the most. And then he also, then what's in store today? Today we have Dr. Jessica Duis and Anna Fengmeyer, and I'm going to be presenting Dr. Jessica Duis as the first speaker. Just again, I want to make sure that you all know that if you have questions, you can just put them in the chat, and then we'll look for them, or you can raise your hand. First of all, I want to tell you a little bit about Dr. Jessica Duis. She trained at Johns Hopkins in Baltimore, where she focused her work on epigenetic disorders. She has built a multidisciplinary center of excellence across the United States with a focus on patient care, establishing standards of care, translational research, clinical trial design, and outcome measures. She's an expert of Angelman, duplication 15q, and Prader-Willi syndromes, and have been published guidelines on their management. Her research has included investigator-driven clinical trials and translational outcome measures designed both in the lab and in the national environment. Dr. Duis is currently collaborating with the Schinzel-Giedion Syndrome Foundation to develop a natural history study and develop standards of care guidelines for SGS. The Schinzel-Giedion Foundation are very pleased to be collaborating with Dr. Duis on these very important projects to increase our understanding of SGS, increase awareness of this rare genetic disease within the medical profession, and to improve the care that our complex children receive to optimize their quality and length of life. It's my pleasure now to hand over to you, Dr. Duis.
Thank you, Karina, for such a kind introduction, and thank you to the SGS Foundation for having me today. I'm incredibly excited to talk with you today about some background of SGS in terms of genetics and clinical findings, and then to present some exciting new programs that hopefully will be rolling out shortly. Just to give a little background about how I got interested in SGS. When I was at Johns Hopkins, I followed a patient during my training and during my postdoctoral fellowship who had SGS, and certainly touched me greatly, working with the family to treat her and learn more about SGS. And this was actually before we had a gene for SGS. And so I'm incredibly excited to be a part of this group. So I thought for this talk, I would actually talk a little bit about some genetic basics and how do you interpret a test report, give a little bit of information about SETBP1, more so from the strategic standpoint of why it's so important to understand this gene molecularly as we move forward in this field, and then talk about the spectrum of findings in SGS. And I want to caution that we are still learning a lot about how this gene works and how mutations impact the gene. And I think that some of this information could even change over the next few years as we learn more. So this is a basic picture of what our chromosomes look like. So all of us have 23 pairs of chromosomes, which include 22 pairs of somatic chromosomes and one germ chromosome. For a boy, it's XY. For a girl, it's XX. And all of us receive one copy of a chromosome from each parent. So one from our father and one from our mother. And we're going to be focusing on SGS, which is caused by mutations in a gene called SETBP1, and that's located on chromosome 18. So taking a step back, in all of our cells, we have our DNA wound into our chromosomes, and our DNA is made up of letters, A, C's, G's, and T's, that make up the sequence of the gene. The function of a gene is to go on to make protein in the body. And so proteins can act individually and all have functions in the body, or they may act in complexes in the body. So when we're talking about genetic changes, we're talking about the DNA and specific genetic changes that affect those letters, the A, C's, G's, and T's, that then go on to have an impact on how the protein functions in the body. And when we think about the impact of a mutation on the function of the protein, what's really important is to understand how those different mutations impact the protein. We can have multiple different impacts that then create a spectrum for what we see with SETBP1. So SETBP1 has been associated with two different classes of disorders. So as was mentioned, SETBP1 haploinsufficiency is one of those, and that tends to be associated with loss of function. What that means is, so for SETBP1, we have two copies of the gene, one on each copy of chromosome 18, one that we get from mom and one that we get from dad. And in the case of SETBP1-HD or SETBP1 haploinsufficiency, we have a mutation or deletion of one copy of SETBP1 that then results in not enough functional protein being made for that to work in the body the way that it is supposed to. Most importantly, when we're talking about SGS, we're talking about a gain of function. What this means is that instead of that change to the DNA affecting the protein in the sense of it not being made, what happens is we actually rev up the protein and make too much of it. So in the case of SETBP1, what happens is you have too much protein being made, and we'll talk about why that happens and the specific parts of the gene that we see changes in SGS that may be causing this to be overactive. The other thing, which I actually think of slightly differently as a gain of function itself, is something called a dominant negative. What that means is you have the function turned up, you make too much protein, but the protein that you do make actually has a toxic effect on the cell itself. So not only do you have too much protein, but the too much protein then has almost a mutant effect of the protein itself to cause toxicity to the cell. And so one of the things that we're still trying to understand for SGS is we know there's a gain of function, but really trying to understand, is there also what is the toxicity that's created by having too much of this protein? in the body, and why does that affect so many different types of cells and so many different organ systems in SGS? So there's still a lot to learn about that, but the key difference to understand is that when you have that loss of function where you don't make functional protein, that looks very different than when you have too much protein being made that then becomes toxic. When we're thinking about doing genetic testing, we always talk about pre-test counseling. And what that is sitting down with the family and trying to make sure that they really understand what the possibilities are with genetic testing. And as I've progressed in my career, I will say this is actually really important, because once you're delivering information to the family, it's often really hard to deliver that uncertain information without having prepared families for it. And that happens quite a bit. So if there's something called a pathogenic change, that means that there's a misspelling or a mutation identified in the gene that actually we know either from having seen other individuals who have the same change and have symptoms of the disorder, or because of where the mutation is and the likelihood that it affects the function of the protein, we often will call these actually pathogenic or disease-causing changes. Sometimes genetic testing is negative, and we always have to have a conversation about that, because even if genetic testing is negative, it doesn't mean that there's not a genetic cause that could be found. It just often means that we're not smart enough at that particular point in time to find the particular change in that patient. And I will say it's possible that we're not finding changes, for example, in regions we don't sequence well, such as in ZBP1, where there could be individuals who are identified who have a clinical picture consistent with SGS, but don't have a genetic change identified. So as we learn more about how this gene gets expressed and how the gene works, it may be that we find individuals who do have SGS, but we haven't identified them yet. I think that's less likely than having individuals who have the ZBP1 haploinsufficiency, and I'll talk about why that is as I progress through the slides. And then lastly, I really want to spend just a little bit of time of talking about these variants of uncertain significance. And the reason I want to talk about that is that we get a lot of questions from families who have identified changes in ZBP1, and we don't really know if they're causing a problem, and if they're the cause of the patient's clinical features. So what that means is that we found a change, and that the lab was uncertain enough of it to report it back to us, but we were not sure if it's actually causing the clinical features that the patient has. And this goes back to something I said when I was talking about negative testing, which is that sometimes we're just not smart enough to understand at that particular point in time the impact of a change in the gene on the function of the protein. And I just want to add to that quickly that this does not constitute a diagnosis. So that's frequently something that happens, particularly I see if other specialties outside of genetics are ordering genetic testing. I'll often get asked about a genetic test result where it's a variant of uncertain significance, but it's been delivered back to the family as a pathogenic variant. And that can create a lot of distress and confusion. So it does not, if we call it a variant of uncertain significance, and even as clinicians, we interpret it and we're still unsure, that means that we need to follow that change and understand that change over time, but it's not a diagnosis. And so I always like to go through a test report, and thank you to Nuala for providing this for me. So When we look at a test report, the kind of the meat of the report is in the table provided in the report right here. And so this mentions a change in SETBP1. This is the specific change in the DNA, the specific point where the change is, and the specific letter change associated with this. So this, you can think of this as kind of like an address of exactly where the change is in our DNA sequence. And then this is the impact on the protein. So this is the particular protein, this is a particular amino acid change that occurs that ultimately has an impact on how the protein functions. Zygosity, so heterozygous means, again, we're coming back to, we have 2 copies of this gene in our body in every one of our cells, one from mom, one from dad. And zygosity means they found this change in 1 copy. And then this interpretation takes into account all this information. Other things that we might think about to help with this interpretation are whether this particular change has ever been seen before in another individual who has symptoms, whether when we look at modeling of the effect on the protein, whether it looks like there is an effect on the protein and how the protein functions in the body. And then the other thing we often do is we have large population databases that will look at something called NOMAD, for example, that has sequencing for what are reportedly healthy individuals, and we'll look and see if this change has ever been reported in healthy individuals, with the thought that if it had been reported, then it would be less likely to be disease causing, versus if it's a rare variant or never been reported in that database, that helps us to make that interpretation of whether this would be pathogenic. And when we talk about recurrence risk, this is a very important part of genetics. Most of the mutations, I would say 95% in SGS, or I'm sorry, 100% are reported to be de novo, but the reason I'm saying 95%, I'll tell you in just a moment. So de novo means that a single egg cell or a single sperm cell has that genetic change that then gets transmitted to the child. And the reason these changes occur is because the replication of our DNA is just an imperfect process. I always describe this to families as if you are writing the same sentence a million times, at some point when you write that sentence down on paper, you miss a letter, you add a letter, you miss a couple of letters. And that is similar to what happens with our genes. These are just random mistakes that occur in our sequence of our DNA. And I always emphasize that there's nothing that a parent can do to change that from occurring. That happens in all of us. All of us carry changes to our genes, whether they be unique to our germ cells, so our single sperm or single egg cell, or something that we carry in our body that we could pass on throughout all of our cells. So nothing that you could have done to change that this occurred, but it's a random event that happens, and then that single egg or sperm cell gets passed on to the child with that genetic change, and then they have it in all of their cells. Sometimes, and the reason I said about 95% are de novo is because there are some reports in the medical literature of more than one sibling having SGS in a family. And in that case, parents are actually completely unaffected. They don't know that they have this change, but it occurred in multiple of their germline cells. So it occurred in multiple sperm or it occurred in multiple eggs that then when they have a child gets passed down more than once. So again, there's no way that a parent can know that they have multiple of these changes, but it has been reported. We often quote the possibility of germline mosaicism as about 1%. And, you know, there are certain disorders where there's a higher rate of the possibility of germline mosaicism. I would not say that that's something that we know about SGS yet, but we do know that germline mosaicism has been reported and something to just be aware of. So SETBP1 was identified in 2010. Like I said, the address of where this gene is on chromosome 18 is at position, I think that's a typo, but I think it's at 12.1. But either way, that's the specific address where the change is. And really important, a lot of what we know about SETBP1 is because of the impact of this gene on developing cancers, particularly leukemia cancers or blood cell cancers, when there's what we call a somatic change. So a somatic change is, instead of having that particular genetic change present throughout the entire body, there's a change that occurs in one single cell that then perpetuates itself in the body. So if you looked at that individual, you would find clusters of cells that have this change in SETBP1, but they don't have it in all their cells. And so we probably wouldn't detect it with some of the ways we collect samples when we're thinking about a change that's present in everyone's cells. We would have to get a specific tissue sample to find that change. And we know that this is involved in methylation of lysine residues on histone tails. So what does that even mean? What that means is that SETBP1 is a gene that's very important for regulating how other genes get turned on and function in the body. So it can impact a wide range of other genes. So we have 23,000 genes about. It can impact the function of those other genes. And that's likely why we see SGS is so multi-systemic, meaning that so many parts of the body are affected by it. We know with SGS that there's this SKI homologous region that's what we call highly conserved, meaning that across many different species, humans, mice, zebrafish, we know that this region of SETBP1 is the same across many different evolutions of organisms that we see. And that just tells us that this is a highly regulated and very important part of our genetics. And so there's a 12 base pair cluster here within this SKI homologous region, or a specific domain of the gene is the best way to think about it, that is often affected when individuals have SGS. And what we know, going back to what I mentioned, is that this is related to a gain of function. So it increases protein stability. And what happens is it affects a domain called the Degron domain, which I'm going to talk a little bit more about in the next slide. But ultimately, what happens is it affects the ability for material to be tagged, to be degraded in the body. And so it just keeps building up within the cell. And like I said, it has been associated with some increased risk of blood cancers when there's those particular somatic changes, so unique to the cell, not present in the entire body. And ultimately, I think the question that you might ask from that is, well, how at risk are these individuals who have a change in this highly conserved region where there's also changes in a single cell in the body that can increase risk of cancer? How at risk are kids with SGS to develop cancer? And this is something that we're still trying to understand, but certainly some of these really highly conserved mutations, in this highly conserved region, mutations or changes or misspellings in the gene do seem to be increased, in particular to have a risk of different types of cancers. So again, this is just a little bit more zoomed in picture of where we see these genetic changes clustering in SGS. And again, in this particular region, these are all associated with that highly conserved Degron region, and I'm going to talk about that right here. So mutations in this hotspot right here that have been reported, and I will say both reported in SGS and myeloid leukemias, or those blood cell cancers, disrupt something called a degron. And like I said, but more specifically talking about the degron, is that it's a signal for the regulation for protein degradation. And if this signal is not working, this is what causes that buildup of the SETBP1 protein within the cell, which does become toxic. And a lot of what we know about this is related to what we know about the function of SETBP1 in the development of this myeloid leukemia or the blood cell cancers. And like I said, a lot of those mutations that are highly associated with that myeloid leukemia cluster in that degron region. And what happens in the cell is there's that higher stability. So instead of what would typically happen would be that degron would tag the SETBP1 protein to be degraded by the ubiquitin proteasome pathway, which is a specific pathway for how our body can degrade and get rid of excess protein. And what happens is that has an impact on other genes. And the other genes that we know about are this particular HOXA gene cluster. And then there's another gene that seems to be very relevant potentially to the treatment of SEPBP1 related disorders and SGS in particular, called PP2A, that also has some increased inhibition through the SETBP1 protein when it's working properly. And so we definitely are thinking the reason it's so important to understand some of these molecular mechanisms is thinking about going forward with precision therapy and treatments for SGS. So basically, the take-home point from this pretty complicated pathway is that what happens in SGS is there's a genetic change in a highly conserved region, and this causes the particular degron sequence, which is responsible for degrading any excess SETBP1 protein, which is toxic, so that it doesn't build up. And that's not functioning properly in individuals with SGS. And one of the things we're coming to learn, which I think we really have a lot to learn about, is that when these particular changes, even though they're within this SKI region or just outside of it, if they don't have as much impact on the degron, then they're more highly associated with a less severe clinical picture than individuals who have the most common changes in that 12 base pair region or the hotspot of the gene. And this does seem to correlate. So work of in the Netherlands has shown that there's a high correlation of whether the genetic change directly affects the degron sequence to the severity of the clinical features. Now, there are some exceptions to that we're learning about, so I don't want anyone to think that's absolute, because we are finding some individuals. There's a recent case report of an individual who had a genetic change that seemed to be in that degron motif, and should affect the degron motif based on where it was, but that individual did have and does have some milder features. So we're still really coming to understand what we call genotype phenotype correlation, or how the particular genetic change affects the clinical features of that individual. And everyone is an individual and has a wide spectrum of features with SGS. But some of the terminology that we've started to use is typical versus atypical SGS, or classical versus atypical or attenuated SGS. And what we mean by that is that there's classical features that are more highly associated with changes in that 12 base pair hotspot region that affect the Degron motif. And then there's some genetic changes that have been reported outside this region, and their clinical features may differ. And in particular, the atypical or attenuated SGS may have some milder features. And so when we look at this, it's very helpful to look at the changes that affect particularly the Degron motif compared to individuals who have changes that might be associated with more atypical SGS. And the things that we find that can be quite different is the severity of neurodevelopmental disabilities and seizures, the presence or absence of hydronephrosis, which was coined as a very important hallmark feature of SGS when it was described clinically. And we're still coming to understand some of the clinical progression of SGS, which I'll talk about in my next talk. And we don't, it looks like it's possible that the progression of disease may be slightly different between the two, but we're still coming to understand that. And then there are things that are very highly associated with SGS, including some resemblance to each other or the facial features of SGS, the GI complications of SGS that seem to be present in the majority of individuals, whether or not they have classical or atypical SGS. So with that, I'll stop with this first talk and be happy to take any questions before I move on to the next talk.
I have a couple, Jessica, if that's okay. Please.
Yeah, please.
When I didn't realize that you were able to pinpoint the zygosity of the gene. Does that mean that you're able to determine whether the mutation is from the sperm or the egg?
So that's a great question. And there are some techniques that we generally don't use clinically, where we can use single nucleotide polymorphisms to try to figure out if it came from the sperm or the egg, but generally we don't make that determination. So the heterozygosity just means we know it's only on one copy of the gene that the individual has a change, but generally we don't go farther to understand if it's on the maternal or the paternal copy in this case.
Okay, thank you. And my other question was in respect of the SETBP1 mutation and the potential with the blood cancer. Is there an argument or a possibility that siblings of children with SGS mutations, could they, so I have an older son, and what I'm thinking is there a possibility that my older son, who doesn't have Schinzel-Giedion syndrome, has some type of SETBP1 mutation that isn't showing now, but could potentially be on a different part of the gene? And then just, I mean, obviously, when my son Jude was born, my husband and I had testing to see whether we had any mutations on our and that wasn't the case. So then it was presumed that it's this kind of de novo or a germline. But I just wondered, is it possible that another sibling could have a different type of SETBP1 or SGS mutation or something on their that same chromosome?
Yeah. So the answer is that we don't quite understand how individuals develop somatic mutations or changes in single cells in their body, but your sons would not have any risk related to having a sibling with SGS. And the reason for that is that if there was any chance of germline mosaicism or something that could have been passed on, your other son would be affected with SGS because it would be present in all of his cells.
Right.
But the reason I say that is that we don't quite fully understand how mutations accumulate in cancers besides those random events that I talked about. And so his risk would be that of the same of the general population to potentially develop a somatic change in SETBP1 associated with an increased risk of leukemia, but very unlikely. You know, the same risk that you or I or anyone else has to develop somatic mutations is still possible, but he would not have any risk related to the fact that he has a brother with SGS.
Right, I understand. Thank you.
Okay. Yeah.
Anyone else having questions? Otherwise, thank you. Sorry, Dana?
Hi, it's Dana. Yes, just a quick question. You were mentioning a few times in your talk that you're still learning about, all of these changes. So can you just give us one example of what it is you focus on to try to learn more?
Yeah, so I think we really need to work towards what we call genotype phenotype correlation, and really looking at all individuals who have a change in SETBP1. And the first step is really nicely curating all the clinical features associated with that particular change in that particular individual. The second step to that is the molecular step of really doing some research to understand that particular molecular change and how it affects expression of the gene, whether that be looking at RNA expression or protein, looking at protein levels and understanding how that really impacts the gene itself. And more literature has come forth showing that it's not as clear. There's been a lot of focus on nomenclature, for example, on how do we name SETBP1 haploinsufficiency, and how do we distinguish that from classical versus atypical, and are there some cases of kind of in between where maybe there's a mostly significant neurodevelopmental features of a change in SETBP1 and maybe some clinical features that also resemble SGS, but also resemble SETBP1 haploinsufficiency. And so really characterizing that whole spectrum, I think, is really important. I have a hunch that we might find that there's a lot more clinical overlap, and it's a lot more gray lines than black and white, truly understanding how this gene works and what the clinical spectrum looks like. And a recent clinical report that came out, which I think I mentioned, but showed that even a patient who had a mutation in that hotspot region, which in other individuals has been associated with more classical SGS, actually was more mild and maybe clinically would be called atypical SGS. And that just tells me we have a whole lot to learn to be able to give more guidance in the clinical management and what to expect for that particular individual with a change in SETBP1.
So just a follow up for that. So you were talking a lot about, what's the phenotype in an individual, right? And so how can we help our families get involved with being able to share that phenotypic information so that we have all of that, in the future to help you?
Yeah, I mean, so the key is those natural history studies and people sharing their information. So people sharing both their genetic information, de-identified reports, so that whoever ultimately curates that information has all the details of exactly the genetic change, and then really nicely characterizing all the clinical features of that particular individual. We know for many genes, not just SETBP1, that there's going to be a huge clinical spectrum associated with changes probably every single gene has a clinical phenotype associated with changes that cause that gain of function versus changes that cause that loss of function. And so the better we can do getting all the information and tracking that information of how it changes over time through natural history studies, the more we're going to know.
Thank you.
Thank you so much, Jessica. That was really exciting.
Oh, thank
Thank
you.
you.
So this talk is going to be talking about specifically phenotype, or the clinical features. And then we're going to get into a little bit about management of SGS, and some of the exciting work that I'm doing in collaboration with NULA and the foundation. So I'm going to review the literature a little bit and some of the classical features of SGS. And like Karina very nicely said, this is something that you all teach me every day working with you. And so this will be very familiar to many of the parents and families. And then I'll talk a little bit about what our clinical experience is, parent input and the importance of parent input and how that's really changed the way that I think about SGS when I'm giving clinical advice for management, and then some of the exciting things that we're doing to really try to establish standards of care for how we manage SGS, and set families up for success, and to feel supported. So I just talked through this, but just a reminder from 5 minutes ago, that, we have this critical domain called the SKA homologous region and genetic changes, particularly in the Degron motif, which is important for how we degrade or get rid of excess that BP1 protein that's associated with SGS. And this is a clinical spectrum, like I said, with many different features. So I'm going to be mostly focusing on what's in the medical literature first, which really I would characterize, even though we don't have genetic testing for a lot of that because it was published before we had identified SETBP1, I'm going to really focus on what is considered, I think, classical features of SGS. So this is really a clinically recognized phenotype that we can see right from the time of birth. And, I think I don't need to describe all these features, but a lot of them right away can be recognized in differences in facial features. And in particular, one thing that's been really nicely described consistently in SGS is that you have, so when your skull comes together, there are openings to the skull called sutures. And as your skull develops, they come together and fuse as you get older to form your skull. And the suture that comes right down, I lost my cursor. Okay, here it is. The suture that comes right down the middle of the forehead is called the metopic suture. And in individuals with SGS, it comes right down almost in a triangular shape, right down all the way to the nose almost, or the bridge of the nose. You can see also that these are very deep set eyes that we see. And the ears can be a little bit low set and different appearing. There can be some excess skin and excess hair on the individual that also might give us some information about the possibility of a genetic change. And then you can kind of see the facial gestalt right here, where you can see this very deep set nasal bridge right here. And then the jaw can be small and recessed or pushed back a little bit. The other features here that I think are really important is that you can see that this infant has a tube to help them feed. And one of the very early challenges that we see with SGS is, in classical SGS in particular, is challenges with feeding. Additional features. So one of the classical features that's been associated with SGS in the medical literature, again, even before we identified the gene, is enlargement of the renal collecting system. You can have uteropelvic junction obstruction. So in particular, there's a lot of renal and neurologic features that can show up even in utero that suggest SGS. And this can be really challenging to manage other things we often see that I think this may be a precursor for, and we may even see in some of the atypical individuals who don't have pylectasis, is atonic bladders. So the bladder just doesn't expand and contract appropriately. The bladder doesn't empty appropriately, and there's an increased risk of urinary tract infections that we see frequently. Congenital heart disease or a structural difference in the heart is very common. In particular, an opening between the left and the right side of the heart, the upper chambers of the heart. So our heart is made up of 4 chambers. The right atrium to the left atrium pumps blood to the heart, to the lungs, and then the left side of the heart receives the blood back and pumps it to the body, in particular oxygenated blood to the body. And so you can have an opening between the right and left side of the heart. And this actually doesn't necessarily get identified right away because it's not often associated with a clear murmur. There are some clinical features that can be the heart sounds, one can be a little bit louder than the other, but that can be really challenging to hear. So it's something to keep in mind, particularly if an ultrasound of the heart has not been done, to just look for this and be aware of it. And then the other common finding that's been classically reported is the corpus callosum, which connects the right and the left side of the brain, is often thinner in individuals who have SGS. A paper in the medical literature showing how the individual facial features evolve over time in this particular infant. And then also there can be genital abnormalities as well, differences in where the opening of the urethra is. As one of them in boys, there also can be cryptorchidism, which the testes don't fully descend. And so that's something to also be aware of when you're examining and thinking about your child. And like I said, differences. So this is just a zoomed in picture showing some differences in the opening of the urethra and some enlargement of the scrotum here, something called a hydrocele. So as individuals get older, so this is a little boy with an EEG on, and you can see this just to indicate that there can be significant seizures, something called infantile spasms, which I'll talk about a little bit more. You can also see in this picture that the eyes are not really aligning well. And one of the things that was brought up, I know yesterday and talked about quite a bit, that's something that is becoming more recognized in SGS is cortical visual impairment. And so we often recognize that quite early where kids with SGS don't track, and there's no clear structural difference of the eye. It's more that their eyes don't seem to align and work together. And ultimately there's a difficulty between what input is coming in with the vision and the ability to process that information functionally to see. The other thing we see very, very frequently in SGS is bowel issues, severe constipation, even obstruction. And many of the kids that I'm aware of or have followed have had significant surgeries required, including history of volvulus. So if this is one thing that's so important that I can't emphasize enough, that I know all the parents are really good about, but if there's any clinicians on the call as well, the importance of when kids with SGS are irritable, it is not personality. There's usually something going on. And so, we're trying to work on some of these standards of care to really think through what that could be. And a portion of those individuals, not all of them, but I would say probably a third of them, it may be related to GI discomfort and even bowel obstruction we've seen. And so I want to talk a little bit more about infantile spasms because this is something you certainly don't want to miss, and you want to treat accordingly and aggressively if it gets recognized. So very early on in the infant period, individuals can develop what's called hypsarrhythmia or infantile spasms. And you can see this is just an extremely disorganized picture of the brain waves of an individual with SGS. And so this needs to be treated aggressively because it can have long-term impacts on neurodevelopmental outcomes. And this seizures and SGS tends to be very progressive. We see this, I think, even with atypical SGS, although it's not every individual with SGS has very difficult to treat refractory seizures, but they seem to be changing all the time. So they are very difficult to treat. It does require continued follow-up and thinking outside the box because of all the changes that occur over time in the types of seizures that they have. And often they would qualify for a diagnosis of Lennox-Gastaut because of the neurodevelopmental impact, in addition to the fact that they have all these different types of changing seizures. And that diagnosis can sometimes be helpful in terms of thinking outside the box and getting kids different types of therapies from an insurance perspective. And then one of the things we're just coming to understand is certainly that in many individuals, particularly with classical SGS, this is from a neurological perspective, a progressive disorder. So not only do we see the corresponding changes on the brain waves, on the EEG, and the different types of seizures, but we also see brain atrophy over time. So you can see that if we start out here, this is more, there's much more brain parenchyma. This is two different types of sequences, but there's much more brain parenchyma here, and then there's a lot more space here. And that's because over time, the brain is what we call atrophying, or the brain is getting smaller. The amount of volume of the brain available is changing over time. And you can see this is a SIR image, and you can see that just shows brightness where those areas where there's fluid. And you can really see that over time that has changed dramatically. And that's something that's more recently reported in the medical literature that we are really following closely and concerned about, and hoping that there's something we can do to intervene to prevent some of these things. So I showed this a little bit earlier. There's definitely a little bit of overlap between the two talks, but just to emphasize, the classical SGS, where they have Degron affecting mutations, tend to be more severe, have more of the clinical features across many different domains, versus the atypical features. They may have less hydronephrosis, they may have less significant developmental delays, they may have less significant seizures, they may have less findings on brain MRI, which we need to understand how that changes in individuals with atypical versus classical SGS as we come to understand the genetic changes and how they affect the protein. So I was really grateful to many families who joined me in a discussion of what they see clinically in their kids, to really start to understand what else are we missing, or what are parents seeing that we just haven't well characterized. And I think this leads very nicely into the next talk on the disease concept model, and just how important we feel that parent input into understanding SGS is. So I've highlighted on the next couple of slides just how multisystemic this disorder is, and some of the things that I really learned a lot about from parents as they went through with me. What are the most significant clinical features that they see, the most distressing, the ones that have the highest impact on their child's quality of life, to understand what do we need to impact to really make a difference in the day-to-day for individuals with SGS, with treatment and precision therapy and doing a better job with standards of care on my mind. So almost across the board, seizures, it was very clear that seizures are a big part of a child with SGS life, especially in classical, but I think also atypical SGS. And that the fact that they're changing all the time, and the fact that they often need someone who's willing to make medication changes in real time and work with them, was very clear. Developmental delays and in particular impact on communication, which I think I have the next slide, but was very clear to be a challenge. And then I can't emphasize enough the impact on urinary function and all the different features that go along with genital urinary differences. And this is something that I also have talked to many clinicians throughout the world about, and really can't emphasize enough how much workup has to be done, even in individuals who don't have hydronephrosis. It is so important to get urodynamic studies. It is so important to follow for urinary tract infections. It is so important to make sure that there's not stones, because coming back to that irritability that we see so frequently in these kids, I think a lot of times clinicians that I've even talked to have said, well, maybe they're just irritable. And I don't think that's true. I think generally they're very happy. And when they're irritable, something is going on that they can't communicate with us. And so I can't emphasize enough that workup needs to be done. And that also comes to some of the risk of embryonal tumors that we see, in particular sacrococcygeal teratomas. These are really under-recognized in SGS. I think a lot more patients have them than we are recognizing, and I can't emphasize enough that there should be screening recommendations that every individual with SGS should have related to this risk of sacrococcygeal teratoma. And we're just trying to understand that. And so I think as parents, it's unfortunate, but as parents, I feel like you're in the position to advocate and educate your providers that that needs to be done. And just additional features, lots of feeding concerns, evaluations to rule out aspirations, really important. GI complications can be extremely challenging. We know these individuals often have decreased intestinal motility, reflux, and severe constipation that needs to be managed aggressively. Communication. So in the through some polls that were done in social media, as well as in that parent group I mentioned, communication is a big challenge and something that's very important to families to figure out how we improve upon. So we have been working on getting something published, gene reviews published, which has been a challenging process because it's not a lot of evidence-based medicine that we can put towards how we manage these kids. And it's very much based on an expert consensus of what we're seeing and the information we really strongly need to get out there. And how do we make that happen when we just don't have enough data to support publication at this point? So we have put together some tables and informations for something like that's called Gene Reviews. And just in case anybody doesn't know what that is, so Gene Reviews is a curated, it's an online publication that for every genetic disorder, their goal is to have a document that talks about the clinical features and how we should be screening and managing those disorders, that can be accessible to providers primarily, although it's available on the World Wide Web when it gets published, and so parents can also access it. And I often, if there is one available for the families that I see in clinic with genetic disorders, I'll actually share it with the family, with the caveat that it can be very technical with a lot of medical jargon in it, and it can also be very overwhelming. But I do think it's incredibly helpful. So this is a table that we've been working on with lots of input from many providers and some parents into thinking about how do we manage SGS. And it goes through development, which for developmental concerns, we strongly recommend getting involved in early interventional therapies very early. as a mainstay of treatment. Epilepsy and some of the things we see, like hips arrhythmia or infantile spasms, and how those might be treated, and different considerations for treatment, the failure to thrive in poor weight gain, hypotonia, the eye findings, and again, CVI, as you heard yesterday, or you heard a nice summary today, that treating CVI can make huge impacts on development for these individuals. And really, that's an educational intervention that can be done to help these kids monitoring hearing, associated cancers. And I can't emphasize enough the importance of screening for these. And hopefully we'll be able to get something into the medical literature to help facilitate that happening. And genitourinary, again, really important to do some early studies to understand how the bladder is functioning, GI concerns, and being aggressive with management. Respiratory concerns, again, often could be related to an increased risk of aspiration. So monitoring for that with aggressive feeding therapy and also following with swallow studies is important. And again, we don't really understand if that is part of what might get worse with time, along with the EEG changes and the cortical atrophy that I showed on that changes with time in the brain. And so that's really important. Making sure there's at least a baseline study for the heart, monitoring skin, dental evaluations. That can also be associated with the irritability. So really important to be something that you're considering and thinking about. And then, of course, family and community support with the SGS Foundation has been fantastic for families and connecting them. So what I really see as the next steps is really working to develop this standard of care. And the SGS Foundation has been integral in kind of connecting with a group that can help us do this in a more systematic way so that we can get something in the medical literature. And then I had a nice opportunity from the questions that were asked to talk a little bit about natural history, but I can't emphasize how much that helps us to move forward in understanding SETBP1 and how the gene works, understanding the clinical phenotype and spectrum of features of SGS and how that relates to those molecular changes in the gene, and then also moving us forward in terms of therapeutics. And then we are working on a model for multidisciplinary care. The challenge with SGS is in creating a center, because it's so multi-systemic, there are many specialists that are needed to effectively make sure that we're not missing anything in individuals with SGS. But our goal would be to create this center of excellence where we can offer appointments for families to see all the specialists they need, and that we all talk to each other and we're all on the same page and we all share our experience to come up with a good plan for that particular individual. And then, so as I mentioned kind of already, we want to develop this center with true expertise, the multidisciplinary care, the natural history, and then the third thing is translational research. And what that is both clinical research to understand how can we measure how SGS changes over time objectively, and then also thinking about rolling out therapeutics for different either drug screens so that we can have effective therapeutics for different aspects of SGS, or ultimately the goal would be gene therapy, or in the case of SGS, a therapeutic to prevent the accumulation of SETBP1 protein in the cell. And so we are working on how do we effectively help this community, with it being people all over the world. And so we are working on setting up some just general educational consultations. So it can't be specific to your child, but what we can do is we can share our experience. And we also want to really help facilitate the effort to collect natural history in SGS. And so I'm really excited about this effort in partnership with the foundation. Okay, and with that, I'll be happy to take any questions.
Thank you so much, Jessica. And thank you. Yeah, it's just, I'm really overwhelmed, and it's amazing to hear how much you know and how much you care about the SGS. Thank you. We have a question. I was wondering about what types of cancers that we should tell our doctors to screen for.
So this is still something we're learning about. I'll tell you what we're doing. We are starting very early on with screening, particularly for sacrococcygeal teratoma. And we've engaged a number of radiologists who don't agree on the best way to do so. But early on, it sounds like you can definitely do a spinal and pelvic ultrasound in the infant period, and then probably this is where the discrepancy is. Either 3, you can do, some people say can do that up to 6 months. Some people say you really need to start doing MRI at 3 months, but we think annual regular pelvic MRI and spine MRI as well, if more information is needed from the pelvic MRI, would be helpful. That's the main thing that we think is really important. I will say I do monitor complete blood counts regularly, and recommend people do that, because that can be, and something called a peripheral blood smear to actually look at the cells. It does sound like, from talking with many, that the cells may not always look typical in SGS anyway, but just kind of monitoring, because we know there is a possibility of potentially some of those blood cancers. Those are the main things that we've kind of been thinking about.
Okay, thank you. We also have another question. Can my doctor contact you, Dr. Duis, for advice about SGS, and how?
Yes, absolutely. So hopefully we're going to be rolling out officially that email address, but anybody is welcome to contact me, and I can give both email addresses in the chat.
And we can circulate them afterwards as well.
Yeah, I'll put my personal one, just because that's not fully up and running yet, but this is the one that we've created.
Yeah. That would be amazing. Thank you. All right. Anyone else having questions?
I think another question, Dr. Duis, would be about language, because we are very much an international community. So if a doctor in a country that didn't speak good English wanted to contact you, or a family wanted to get in touch to try to put their doctor in touch with you, how would they do that if they don't speak good English?
Yeah, so you could email that email address in another language. You might need to give it slightly more time to get a response, but we can always translate that. And then the other option is so we would start with that. And then if we need to have a phone call with your local doctor, we have access to interpreters for all of our phone calls. So we have access to interpreters for about 430 languages. So hopefully we would be able to get an interpreter for the particular language.
Super.
Yeah.
And I say that because we were contacted by a family that spoke a language that I have not been able to find an interpreter for. So that's why I say I hope, but we mostly have not had difficulties.
I just have a question as well. Is the hope ultimately that, leaving kind of ethical issues aside as to whether prenatal screening is the right thing and decisions, but is the hope that there will somebody who has an unborn child with some symptoms of SGS, is the hope that we will be able to diagnose that condition before birth and therefore have all of those things in place, or certainly being talked about with the parents and talked about with clinicians involved in the care in a kind of more organized, shall we say, rather than fighting fire manner, in which, in my experience, a lot of the treatments and things that my son started to need, it was almost emergency situations. He needs this, he needs that. is the hope then in terms of genetics and identification of SGS? Is that what the general hope would be?
Absolutely. The general hope is that we'd be able to, and I think this is changing. So the general hope is that we would diagnose in utero, prepare the families, and have some clear guidance of what screening we need to be doing and how we need to treat SGS, and ultimately have a treatment for SGS. And that's a, 20-year plan. I just want people to know that that's not something that we'll have tomorrow. We want to have it tomorrow, but I think we want to be realistic about what that looks like. But I think what we can be doing now is providing that guidance, because we have had a lot of emergency situations, for example, related to people developing that sacrococcygeal teratoma. And if we had the guidance to say, right from birth, you need to be screening from this, at least we catch it early, at least we take care of it early, and we don't have those periods of not knowing what's going on and scrambling, which I think is
it's
common.
Super difficult, isn't it? I think my experience is when they're born, it's literally like one thing comes out, oh, there's something else, oh, now there's something else, now there's something else. And I think it would have been so helpful to have, right, this is the diagnosis and these are the things you can expect, not necessarily will happen, but just to be forewarned. To be forewarned is to be forearmed, isn't it? And
exactly.
And that, I really feel that's super important to get that point across to parents of newly diagnosed children, is that's why we're asking for the information from parents, is to anticipate things for children born in the future.
Absolutely. I totally agree that that's the key.
I can see that we have a question in the chat from Rafe Garvin. We never really talk about how SGS children are affected by generally found pathogens. Are children specifically more or much more vulnerable than normal children? If so, what do we need to be particularly aware or careful about?
Yeah, so I don't know that we know enough to know if it's the particular change in the gene and maybe set BP1, we talked about that methylation, maybe it regulates some immune genes. In the workups that I've seen for kids with SGS, their immune system seems to be working okay. The challenge is, I think, the secretions and the low muscle tone that we often see just makes them a lot more susceptible to pick up pathogens, viral illnesses. And then when they do get them, they tend to get a little bit more sick because of the challenges of handling their secretions and the respiratory challenges that go along with some of those. In particular, I think it's some of the, like when we talk about pathogens related to urinary tract infections, I actually think it's that underlying structural difference in how the bladder works and is innervated by the brain and the nervous system. And so it's that if the bladder's not working functionally and there's urine that sits in the bladder, it's very prone, for example, to get infected with a pathogen. And then the more times that happens, the more bugs, different types of bugs that you get that are resistant to the typical antibiotics we use. And so I don't know that there's an immune problem per se, but they're certainly more susceptible to infections. So one of the things that we really recommend is aggressive, what we call pulmonary toilet in here, which is, chest physiotherapy, making sure you're aggressively on nebulizers and treating appropriately to try to help bring up secretions and help prevent worse viral infections that progress to pneumonia. And then also really understanding how the bladder is working for that individual. Because kids with SGS are really at risk, in my experience with directly, really at risk for getting bloodborne infections because people don't recognize that they have a bad UTI. People don't recognize that there's something going on. And that's something that I'm really working hard, with the foundation to educate people about so that we don't miss those things and cause a bigger problem.
Absolutely. So a quick question Jessica, do you think, I know our kids have structural problems that we wouldn't be able to change. So they're born with abnormal kidneys and we can't change that after birth. But their gut, as far as I know, is not necessarily different from another child's gut. Do you think a lot of the gut problems that we see, and some of our kids get awful reflux and bloating, Emma, I mean, you had a pretty bad experience with Jude, and you might want to elaborate a bit on that, but do you think that's all due to the brain? And if we were somehow able to find treatments that improved the brain function, we might see a secondary improvement in the gut function, maybe the bladder function, even if we couldn't change the kidney structure. I don't know, Emma, if you wanted to elaborate a bit with your experience.
Yeah, so Jude had a lot of problems with gas and wind and constipation, to the point he was so incredibly uncomfortable. So when you were saying it's not a fact, I remember a doctor specifically saying to me, actually, oh, maybe he's just a bit grumpy. And I was like, no, there's definitely something else wrong. It's not just the fact that he's a grumpy child. And we ended up having to do daily bowel washouts using a flatus tube and saline and then sterilized water just to relieve the gas. And they were horrific for everybody in many ways, but incredibly successful in terms of the relief they gave him. But we tried everything, all medication, you name it, he tried it. And the one that actually seemed to have some effect was on ondansetron, which is what I understand has a neurological effect, as in it seems to, it stops, I understand that it tells your brain to stop being sick, and that seemed to relieve his reflux and seemed to help the constipation. So I mean, is there a neurological element to all of that? It seems quite poorly understood.
Yeah, so this is an area where we see in many neurodevelopmental disabilities that the GI concerns can be quite significant. And I absolutely think it's neurologically mediated and affects, for example, a lot of how the gut moves, like peristalsis of the gut is highly neurologically tied. And so I do think if we figured out how to improve some of the neurological aspects, then we could make a big difference for the gut as well. Absolutely. Yeah.
All right.
Super.
Anything else? We are 3 minutes away from you having to go, Jessica. So
I have a quick question. Hi, it's Dana. And just a 30-second response, Dr. Duis, if you may. So you mentioned natural history study, and we also have a registry. So can you just tell us in a quick summary, what's the difference between the two, and how do parents get involved?
Yeah, so that's not a 30-second answer, but I'll try.
Okay. Sorry.
I think they complement each other.
Okay.
So I think of a true natural history study as, coming to a site, or if we could figure out how to do it via telehealth, much better, but coming to a site and collection of neuropsychological measures, collection of EEG, collection of bladder urodynamics, collection of all kinds of things that we can do in a clinical setting. And then the patient registry is really to support that. So that's the patient questionnaires, the ORCA questionnaire that was mentioned. So, many other types of questionnaires that you can add just to get medical history and follow complications of SGS or, so I think they complement the two and they need to be highly tied together. But true natural history, I think of as needing some of those more objective assessments.
Okay, thank you. So tomorrow we're going to spend a lot of time talking about registry and what a registry is, and we're going to share a bit about the SGS registry. So thank you for making the distinction for us. Thank you.
Absolutely. Thank you so much for having me. I'm sorry I have family duties, but I'm always happy to talk more and receive emails and help in any way that I can. So don't hesitate to reach out to me if you didn't get your question answered.
Thank you so much, Dr. Duis, for a really informative series of talks. Leading on really well from Dr. Duis's talks is our next talk in the session by Anna Fangmeyer, who is a genetic counselling master's student at Vanderbilt University, and Anna will be telling us about the disease concept study which the SGS Foundation are collaborating on with Combined Brain and Vanderbilt University. And this is a really important study for us as the SGS community to get involved with, and you can learn how you can get involved as a parent or caregiver of a child with SGS, because this study focuses on which symptoms and signs of SGS are most important to you as a parent or caregiver, and which ones you think really impact your child the most. And this is why it's so important, so that those caring for our children, the medical professionals and other healthcare professionals, as well as researchers involved with SGS, really understand what the key aspects of the condition are that impact us as families on a day-to-day basis, and therefore we can focus our efforts on developing new treatments and focus our research efforts really on the symptoms that matter most and trying to alleviate those. So please do take the time to listen to that talk, and if you are a parent or a caregiver of a child with SGS, we really hope that you will want to get involved in this exciting study. Thank you.